Welcome back. Today we are undertaking a deep dive into the world of cardiac electrophysiology.
Yeah, it's a fascinating area. Rapid rhythms, dropped beats, lots of high-stakes decisions.
It's basically plugging right into the heart's electrical circuit today.
That's a good way to put it. And we've got a massive stack of sources here, covering everything from, the really common stuff like atrial fibrillation,
AFib.
all the way to pretty immediate life threats. Things like conduction defects, drug toxicities people might not even think about.
Right. So our mission really is to cut through the noise. We need to figure out how to quickly spot the difference between something that's, well, basically fine
Just watch and wait.
and something that's a genuine emergency. Like,
Well-
when do you pivot? When does management totally shift from, say, giving a drug to needing electricity? Like, right now.
Exactly. And we'll connect some dots too. Like, why can heart failure from a fast heart rate sometimes just go away?
Yeah, that reversibility is key.
And the danger when certain arrhythmias like collide, plus
Yeah.
that one lab test, the thyroid one, why it's absolutely crucial for anyone with new AFib.
Okay, let's dig in. It's a huge topic. Where better to start than the big one? Atrial fibrillation, AFib. So AFib, millions have it. We hear rhythmic chaos. What's actually happening electrically? What are we looking for on that ECG strip?
Well, AFib is basically disorganized electrical noise in the atria. Instead of that nice, clean signal from the SA node,
The normal pacemaker.
right, you get all these tiny, chaotic wavelets just swirling around. So on the ECG, two things jump out. First, you lose your P waves entirely. The atria aren't contracting properly. They're just fibrillating, quivering.
Makes sense.
And second, because the AV node is getting bombarded randomly by all this chaos, the ventricular response to QRS complexes, they become completely irregular. We call it irregular, no pattern to it at all.
That pattern, that chaos.
Yeah.
It doesn't just happen out of the blue, though. The forces talk about two main drivers. The long-term changes, the substrate, and then the acute triggers.
Yeah.
Let's start with the substrate. What kind of chronic stuff sets the stage?
Yeah, the substrate is the physical change in the heart muscle itself. Scarring, dilation, fibrosis, things that let those chaotic circuits keep going. And the number one cause, like the most common culprit by far, hypertension.
High blood pressure.
Chronic, poorly controlled high blood pressure. Over years, it just remodels the left atrium. But there's other stuff too, of course. Getting older is a big one. Mitral valve problems, especially stenosis, anything that puts long-term strain on the atria, really. Like LV dysfunction.
And what about, more modern factors? Obesity, sleep apnea. Our sources flagged those.
Oh, absolutely huge. Obesity and OSA, obstructive sleep apnea, they're major players now. With OSA, you get these big swings in chest pressure overnight that literally stretch and stress the left atrium again and again. That causes inflammation, remodeling, basically primes the pump for AFib. And things like COPD, chronic lung disease. Same idea, raises pressures that eventually affect the atria.
Okay, so that's the background, the fertile ground, so to speak. What about the sparks, the triggers that actually kick off an episode? Two classic ones mentioned.
Yeah, the first one is the famous holiday heart syndrome.
Ah, the post-binge AFib.
Exactly. Someone has a bit too much alcohol, and boom, they flip into AFib. Alcohol itself, plus its metabolites, mess with the atrial tissue's electrical properties and ramp up sympathetic tone.
And the key point there.
The key is, if the person doesn't have other big stroke risk factors, their CHA Eurovasc score is low, this type of AFib is often temporary. It goes away once the alcohol clears. Might not even need long-term treatment like anticoagulation.
Okay. And the second trigger, the one you said was diagnostically critical, the endocrine connection.
Hyperthyroidism. This is non-negotiable. You have to check a TSH level in every single patient with new onset AFib.
Why is it so important?
Because an overactive thyroid floods the body with thyroid hormone, which massively cranks up the sympathetic nervous system. Heart rate goes up. The heart muscle itself becomes more excitable. It's a perfect trigger for AFib. And if you miss it, you can pile on beta blockers, calcium channel blockers.
All the rate control drugs.
And it won't work long term. The AFib will just keep coming back until you treat the underlying thyroid problem. So missing hyperthyroidism means failing the AFib treatment. Simple as that.
Got it. And just a quick technical point, where do these triggering electrical signals often start? The sources mentioned a specific spot.
Yeah, it's interesting. While the whole atrium might be diseased, the actual sparks often fly from the muscle sleeves that extend into the pulmonary veins.
the veins draining blood from the lungs into the left atrium.
Exactly. And that anatomical fact is why a common procedure for AFib, pulmonary vein isolation, or PVI ablation, works. They go in and essentially electrically fence off the pulmonary veins, stopping those bad signals from getting into the atrium.
Okay, let's shift to complications. The big fear with AFib is stroke. How does that disorganized beat lead to a clot?
It's all about stasis. Because the atria are just quivering, instead of giving a good squeeze, blood flow slows right down and gets sluggish. And there's this little pouch off the left atrium, the left atrial appendage, or LAA.
Like a little ear?
Kind of, yeah. Blood tends to pool in there during AFib, doesn't get cleared out well. And that stasis is the perfect setup for a clot to form. It's Virchow's triad kicking in.
And that clot can break off, travel to the brain,
Yeah.
stroke, or elsewhere, like causing a cold leg, right? Acute limb ischemia.
Precisely. Stroke is the main danger we worry about. But there's another one linked to the fast heart rate itself. Tachycardia-induced cardiomyopathy. You mentioned the reversibility earlier. Let's unpack that.
Yeah, this seemed really important. Heart failure caused by just a fast rate.
It is. If the ventricles are beating way too fast, say 140, 150 beats per minute constantly for weeks or months, that sheer workload wears them out. They get tired, dilated, and the ejection fraction, the pumping strength, plummets. Patient looks like they have heart failure.
But it's not like a heart attack damage.
No, that's the critical difference. It's not ischemic damage. It's more like metabolic exhaustion of the muscle. The amazing thing is, if you get the heart rate under control, either controlling the rate in AFib or converting back to a normal rhythm, that ventricular dysfunction is often completely reversible. The EF can bounce right back to normal over time.
That's huge. Huge implications for patients. Okay, management. First step, always, stability. How do we define stable versus unstable here?
Yeah, first things first. Check the vital signs in the patient. Are they unstable? That means things like severe low blood pressure, signs of shock, like cool, clammy skin, confusion, acute heart failure symptoms like sudden shortness of breath, crackles in the lungs, or ongoing chest pain suggesting ischemia.
And if they are unstable?
No messing around with drugs. Immediate synchronized electrical cardioversion, DCCV.
Yeah.
You shock them back into rhythm. Now.
Okay, but if they're stable, blood pressure's okay, they're not in acute distress.
Then we usually go with weight control first. Slow the heart rate down.
What are the go-to drugs for that, and what rate are we aiming for?
The workhorses are drugs that slow down the AV node. So first line is typically either a beta blocker, like metoprolol, or a non-dihydropyridine calcium channel blocker, think diltiazem or verapamil.
Okay.
Acutely, the goal is often just to get the resting heart rate under 110, get them comfortable. Long term, though, especially if they have symptoms or other heart conditions like coronary artery disease, you might aim for a stricter control, maybe less than 80 beats per minute at rest.
Where does digoxin fit in? It's an older drug.
Digoxin's more of a second line or add-on agent usually. It works differently, mainly by increasing vagal tone to slow the AV node, which takes a bit longer, its main advantage. It slows the rate without weakening the heart's contraction. It's not a negative inotrope.
Ah, so it's useful if the patient already has a weak heart, like existing heart failure.
Exactly. Or if you need a bit more rate control on top of a beta blocker or CCB.
Okay, rate control sorted for the stable patient. Now, the massive long-term decision. Anticoagulation, preventing those strokes. It all comes down to the CHA Euro-FS score, right?
Absolutely. That's our standard risk calculator. We need to know how to use it.
Break it down for us. What do the letters stand for, and which ones give you double points?
Okay, C is congestive heart failure. H is hypertension. A Euros is age 75 or older. That's the 2 points right there. D is diabetes. S is prior stroke, TIA, or thromboembolism, also 2 points. V is vascular disease, like prior heart attack, peripheral artery disease. A is age 65 to 74, that's 1 point. And SC is sex category female, counts for 1 point, but only if other risk factors are present.
So the big hitters, 2 points each, are age 75 plus and prior stroke TA.
Correct. They carry the most weight.
And what's the magic number? When do we pull the trigger on starting anticoagulation?
It's pretty clear cut. A score of 2 or more in men, or 3 or more in women. If they hit that threshold, they need oral anticoagulation, OAC.
And the sources strongly favor the newer drugs, the DOACs, over warfarin now.
Right.
Why is that? What's the advantage of, say, Pixaban or rivaroxaban?
Yeah, DOACs are generally preferred. 3 main reasons. First, and maybe most importantly, they have a significantly lower risk of causing bleeding inside the brain, intracranial hemorrhage, which is a really devastating type of stroke.
That's a major safety benefit.
Huge. Second, they have far fewer interactions with food and other drugs compared to warfarin, which is notoriously finicky.
No more avoiding leafy greens.
Well, not for the drug's sake, no.
Yeah.
And third, their effect is much more predictable. You don't need the constant blood tests, the INR monitoring that you need with warfarin. It's just much easier for patients.
Okay, and just to hammer this home, aspirin is not enough, right?
Absolutely not. The evidence is clear. If your CH-Euro's VAS score is high enough to warrant anticoagulation, aspirin alone does basically nothing to prevent the kind of strokes caused by AFib clots. You need a real anticoagulant, a DOAC, or warfarin.
Okay, that's a solid look at AFib. Let's shift gears now to some other electrical problems where the danger can be much more immediate, starting with that classic shortcut, Wolff-Parkinson-White syndrome, WPW.
Right, WPW is what we call a pre-excitation syndrome. Normally, the electrical signal goes from the atria, pauses at the AV node, that pause is crucial, and then goes to the ventricles.
Gives the ventricles time to fill.
Exactly. But in WPW, there's an extra electrical connection, an accessory pathway, often called the bundle of Kent. It's like an electrical bypass tract around the AV node.
Superhighway.
Pretty much. It lets the signal zip straight from the atrium down to the ventricle, skipping that AV node delay.
And how does that show up on the ECG, that classic triad?
Okay, 3 things. Because you skip the AV node delay, the PR interval, the time from atrial to ventricular activation, gets short, really short.
Makes sense.
Then, because the ventricle starts getting activated early via the shortcut before the normal signal arrives through the regular pathway, the QRS complex looks wide. And crucially, you see the delta wave.
Ah, the delta wave. Explain that.
It's that characteristic slow, slurred upstroke at the very beginning of the QRS. That slurring is the initial early activation of the ventricle via the accessory pathway. Short PR, delta wave, wide QRS, that's WPW.
Now, someone can have that pattern and be fine for years, but the source is called AFib plus WPW, a fatal combination. Why is that specific mix so incredibly dangerous?
It is potentially lethal. Think about it. In AFib, the atria are firing chaotically at maybe 300, 400, even 500 times a minute.
Wow.
Normally, the AV node blocks most of those crazy fast signals protecting the ventricles. But if you have that accessory pathway, that WPW superhighway, it doesn't have the same filtering ability. It can conduct those signals super rapidly, maybe 1-to-1, down to the ventricles.
So the ventricles start beating at 300 plus.
Exactly. And that incredibly fast, chaotic ventricular activation very quickly degenerates into ventricular fibrillation, VFib. And VFib means cardiac arrest, sudden death.
Okay, so if you have a patient in AFib and they have WPW, you see those delta waves on the ECG, the management is totally different. You absolutely cannot use the standard AFib rate control drugs.
Correct. This is a critical life-saving point. Do not give AV nodal blockers. That means no adenosine, no beta blockers, no calcium channel blockers like diltiazem or verapamil, and especially no digoxin.
Why not? What happens if you do?
Because those drugs work by slowing conduction through the normal pathway, the AV node. If you block the normal pathway, you force all those rapid AFib signals down the fast accessory pathway. You actually make the ventricular rate even faster and guarantee that descent into VFib.
Wow. So you make things worse. What do you use then, acutely?
You need drugs that slow or block conduction through the accessory pathway itself. The main choices are procainamide, or sometimes edutolide, or if they're unstable, immediate electrical cardioversion is needed.
And the long-term fix?
Definitive treatment is catheter ablation. Go in and burn or freeze that accessory pathway to get rid of it permanently.
Okay, let's move to AV blocks, another area where diagnosis matters hugely. Mobitz first, Syncope, versus Mobitz the second and a third-degree block. They sound similar, but worlds apart clinically.
Totally different beasts. Mobitz type I, or Syncope, is the one where the PR interval gets progressively longer. Longer? Longer. Then pop, a beat is dropped, no QRS. Then the cycle repeats.
The waxes and waning PR interval.
Exactly. And the key is where the block usually is, high up, in the AV node itself. The AV node can do this sort of thing. It's often related to high vagal tone.
So who gets Syncope? Is it dangerous?
Often, no. You see it quite a bit in really fit athletes because they have high vagal tone. You can also see it during sleep. Patients are usually totally asymptomatic. It rarely progresses to a worse block, so it's typically just observed.
Okay, benign. Now contrast that with Mobitz type 2. Where's that block, and what's the ECG difference?
Mobitz 2 is much more concerning. The block isn't in the AV node. It's lower down in the his Purkinje system, the wiring within the ventricles.
Okay.
And the ECG looks different. The PR interval is constant for several beats, and then suddenly, out of the blue, a QRS is dropped. Constant PR, then a drop. That's Mobitz 2. And because it's below the AV node, it's much less stable, much more likely to progress suddenly.
Progress 2, third-degree block.
Potentially, yes. Third degree or complete AV block is when there's zero communication between the atria and ventricles. Complete AV dissociation. The P waves just march along at their own atrial rate, and the QRS complexes march along at a separate, much slower ventricular escape rhythm, usually very slow, like 20 to 40 beats per minute.
So the management difference is huge here.
Night and day. Mobitz Vancobach is usually observation, but Mobitz the second and third degree AV block, these are serious. They carry a high risk of the heart just stopping sudden asystole.
Yeah.
They almost always require a permanent pacemaker.
And just like with WPW, you avoid certain drugs.
Absolutely. Never give AV nodal blocking agents to someone with Mobitz the second or third degree block because you might suppress that vital slow escape rhythm that's keeping them alive.
Got it. Now let's touch on two conditions where syncope, fainting, is often the scary first sign. Hypertrophic cardiomyopathy, HCM, and cardiac sarcoidosis.
Right. HCM first. This is usually genetic. You get this abnormal thickening of the heart muscle, especially the septum, the wall between the ventricles.
Asymmetric thickening.
Yeah, and that thickened septum can bulge into the left ventricular outflow tract, the path blood takes leaving the heart. It obstructs the flow.
And the classic story is?
A young, seemingly healthy person fainting, especially during or right after exercise, exertional syncope.
Why specifically with exertion? What's happening mechanically?
Okay, during exercise, your heart beats faster, right? So there's less time for the ventricle to fill between beats. Tummy load goes down. At the same time, the heart is contracting more forcefully. This combination, low volume, forceful contraction, makes that outflow tract obstruction much worse. There's actually a Venturi effect. The fast flow through the narrowed opening sucks the front leaflet of the mitral valve forward right into the outflow tract, blocking it even more. Cardiac output plummets suddenly, blood flow to the brain drops, and syncope.
And that dynamic obstruction also explains the weird murmur, right? The one that changes with maneuvers.
Exactly. The systolic murmur of HCM gets louder or worse when you do things that decrease preload, like standing up quickly or doing a Valsalva maneuver, bearing down. Less blood in the ventricle makes the obstruction more obvious.
Okay.
But it gets quieter or softer if you increase preload or afterload, like squatting or gripping something hard. More blood volume stretches the ventricle and lessens the obstruction. It's a very specific finding. And the big danger with HCM is sudden cardiac death from VT or VFib. So often these patients need an ICD.
Okay. And the other cause of syncope, often missed, cardiac sarcoidosis.
Yeah, sarcoidosis is that inflammatory disease where you get granulomas, little clumps of inflammatory cells forming in different organs. If they form in the heart,
They can mess up the wiring.
precisely. They infiltrate the conduction system and physically block the electrical signals. You should really suspect cardiac sarcoid in younger folks, say under 55, who show up with unexplained heart block, especially new onset complete AV block or other arrhythmias, particularly if they have other signs of sarcoid like eye inflammation, uveitis, or weird stuff on a chest x-ray.
Yeah, let's move to the really acute stuff. Cardiac arrest. The sources say survival from sudden cardiac arrest, SCA, really hangs on one thing more than anything else.
Time to defibrillation, simple as that.
Yeah.
SCA in adults is usually caused by VFib or maybe pulseless ventricular tachycardia, pulseless VT, often triggered by a lack of blood flow, ischemia.
Right.
CPR is vital, absolutely essential to keep some blood flowing to the brain and heart. But CPR doesn't fix VFib, only electricity does, the shock.
What?
Defibrillation. The sooner you get that shock delivered, the better the chance of survival.
Okay, the shock. Big point of confusion sometimes. Synchronized versus unsynchronized. When do you use which? Getting this wrong is bad.
Very bad. Okay, here's the key difference. Does the patient have a pulse? If they have unstable tachycardia with a pulse, meaning they're alive, but crashing fast, hypotensive, maybe pulmonary edema, altered mental status, you use synchronized cardioversion.
Synchronized, why?
The machine looks for the R wave on the ECG, the peak of the QRS, and delivers the shock exactly then. This avoids shocking during the T wave, which is the vulnerable period for repolarization. Shocking on the T wave could actually cause VFib, so pulse present, unstable, synchronized shock.
Got it. And if they have NO pulse, they're in cardiac arrest, VFib, or pulseless VT.
Then it's unsynchronized defibrillation, immediately. High energy. There's no organized rhythm to synchronize to. The heart's just electrically chaotic. You just deliver the shock as quickly as possible to try and stun everything and let the heart's own pacemaker hopefully take over. No pulse, unsynchronized shock.
Okay, clear distinction. Cardioversion for unstable pulse, defibrillation for no pulse. And thinking preventatively, who's at highest risk for these lethal arrhythmias later on?
Patients who've already had a significant heart attack, an MI, and it's left them with a badly damaged left ventricle, specifically an ejection fraction, or EF, of 30% or less.
Even if they feel okay now.
Even if they feel okay now. That scarred, weakened ventricle is prone to developing VT or VFib later. So those patients are often candidates for an implantable cardioverter defibrillator, an ICD, for primary prevention to shock them automatically if a bad rhythm occurs.
Okay, let's loop back to syncope one last time, focusing on how to tell the harmless faint from the dangerous one just by listening to the story. Vasovagal versus arrhythmic.
History is absolutely king here. Vasovagal syncope, the common faint, is usually benign. The hallmark is a prodrome.
A warning phase.
Yeah. The person feels it coming on. They get warm, sweaty, nauseous, look pale before they pass out. And there's usually a trigger: standing too long, the sight of blood, strong emotion, pain. Recovery is typically quick and complete once they're horizontal.
And for people who get these often, what can they do?
We teach them counter-pressure maneuvers. Things like crossing their legs tightly, tensing their arm muscles, gripping their hands together. If they do these as soon as they feel the prodrome starting, it can often raise their blood pressure enough to stop the faint from happening.
Simple, but effective. Now, contrast that with the scary kind, rhythmic syncope. What are the red flags?
Red flags all over. This is the dangerous one because it implies a sudden, severe drop in cardiac output, likely from an arrhythmia. The key features are sudden onset with NO prodrome, or maybe just feeling lightheaded for a second right before blacking out. It often happens without warning, even while sitting or lying down, or sometimes during exertion.
So abrupt, no warning.
Exactly. That pattern suggests a sudden heart block, like Mobitz II or third degree, or maybe a burst of ventricular tachycardia. And one other point, sometimes people who faint might have a few muscle jerks.
Like a seizure.
It can look like it, yeah. Myoclonus from the brain, not getting enough oxygen. But the sources point out that lateral tongue biting the side of the tongue, is highly specific for a true seizure, much less common in syncope.
Good clinical pearl.
Mm-hmm.
Okay, let's wrap this section with drug toxicities. Amiodarone, digoxin, haloperidol. Amiodarone, first great drug for rhythm control, but lots of baggage.
Oh yeah, amiodarone works well, but it sticks around for ever incredibly long half-life and hits multiple organs. We have to talk about the two big non-cardiac worries. First, pulmonary toxicity.
The lungs.
Yeah, it can cause this sneaky progressive scarring called interstitial pneumonitis. Patients get gradually more short of breath, develop a dry cough. You see characteristic changes on imaging, and their lung function tests show a restrictive pattern, difficulty getting air out. It's serious, needs stopping the drug, often requires steroids.
Okay, lungs. What's the second big one?
Thyroid. Amiodarone is packed with iodine, and it messes with the thyroid in complex ways. It can cause both hypothyroidism,
Underactive thyroid.
due to something called the Wolff-Chaikoff effect, where the excess iodine shuts down hormone production. Or it can cause hyperthyroidism, an overactive thyroid. And there are actually two types of that.
Two types of amiodarone-induced thyrotoxicosis.
Yeah. AIT type 1 is where the iodine load just fuels more hormone production in someone with underlying thyroid disease. AIT type 2 is more like a destructive thyroiditis. The drug damages the thyroid gland, causing stored hormone to leak out.
Does the type matter?
Matters hugely for treatment. Type 1 you treat with anti-thyroid drugs. Type 2 you treat with steroids to calm the inflammation. So, bottom line, anyone on amiodarone needs regular thyroid function tests, TSH, and liver function tests, LFTs too, constantly.
Okay. Next up, digoxin toxicity. Still used sometimes, right? What's the classic ECG finding we need to know?
Digoxin works on the sodium-potassium pump in heart cells. Toxicity messes with calcium levels and increases vagal tone. The pathognomonic, like the super characteristic arrhythmia of digoxin toxicity, is atrial tachycardia with AV block. The atria are firing fast, but the AV node is simultaneously blocked, so not all those fast beats get through.
Weird combo.
It is. And symptoms are often vague nausea, vomiting, loss of appetite. The classic yellow vision, xanthopsia, is actually pretty rare.
And the interaction with amiodarone is critical here.
Absolutely vital. Amiodarone significantly increases digoxin levels, probably by inhibiting its clearance. If you start amiodarone on someone already taking digoxin, you must cut the digoxin dose, usually by 25% to 50% right away to avoid toxicity.
Good rule of thumb. Finally, haloperidol. Commonly used antipsychotic, especially 5E in the hospital. What's the cardiac risk?
5E haloperidol specifically can block certain potassium channels in the heart. This prolongs the QT interval on the ECG.
Long QT risk of torsades.
Exactly. Risk of torsades de pointe, that twisting polymorphic VTAC. So, especially if giving it IV or in patients with other risk factors like low potassium or magnesium, you really should get an ECG beforehand to check the baseline QT interval.
And if torsates does happen, what's the treatment?
IV magnesium sulfate, bolus, then infusion. Magnesium stabilizes the heart muscle membrane. It's the go-to treatment for TDP, even if their magnesium level is normal.
And while we're on antidotes, what about for a beta blocker overdose? You mentioned glucagon. Why that?
Yeah, glucagon, it seems counterintuitive, maybe, but
Yeah.
beta blockers block the beta receptors on the heart cell. Glucagon works through a completely different receptor.
Bypasses the blockade.
Exactly. It activates adenyl cyclase independently, ramping up intracellular cyclic AMP, CAM-AMP, and increased CAM-AMP improves heart contractility and heart rate, effectively overcoming the beta blockade. It's a neat pharmacological trick.
Okay, let's bring it home with some prevention strategies and managing common side effects. Statins first. Who absolutely needs one for primary prevention, basically no matter what their LDL cholesterol level is?
The guidelines are pretty emphatic now. Two main groups. First, anyone age 40 or older with type 2 diabetes. Doesn't matter what their LDL is, they get a statin.
Diabetes itself is considered that high risk.
Yes. And second, anyone aged 40 to 75 without diabetes, but whose calculated 10-year risk of atherosclerotic cardiovascular disease, the ASCZD risk score is 7.5% to 10% or higher. They need at least a moderate intensity statin, maybe high intensity, depending on the exact risk.
Okay. Now, a tricky interaction. Treating high blood pressure in someone who also has diabetes. You mentioned the choice of beta blocker really matters.
It absolutely can. Those standard beta blockers like metoprolol, atenolol, even the non-selective ones like propranolol, they can actually make insulin resistance worse. They block beta-2 receptors in peripheral tissues, which normally help with vasodilation and glucose uptake into muscle. Blocking them can impair glucose handling. So for someone with both hypertension and diabetes, the preferred beta blockers are often the ones with combined alpha and beta blockade, like carvedilol or labetalol. The alpha blockade seems to counteract those negative metabolic effects.
Interesting nuance. Let's tackle that super common side effect. Ankle swelling from calcium channel blockers like amlodipine. People often just get prescribed a diuretic, but you said that's usually the wrong move.
Yeah, classic mistake. That edema, the swelling from drugs like amlodipine, isn't primarily about volume overload. It's about pressure dynamics in the tiny capillaries.
Explain that.
Amlodipine is great at dilating arteries, the small arterioles bringing blood into the capillaries, but it doesn't dilate the veins on the other side as much, so you get high pressure building up inside the capillary, forcing fluid out into the tissues.
Pressure gradient issue, not a fluid overload issue.
Exactly. So a diuretic, which just makes you pee out salt and water, doesn't really fix that underlying pressure imbalance in the capillary bed. It often doesn't help much with the edema.
So if diuretics aren't the answer, what is the fix for CCB-induced edema? It sounds counterintuitive.
The best trick is often to add an ACE inhibitor or an ARB.
Add another blood pressure drug.
Yeah. Because ACE inhibitors and ARBs work well at dilating the venous side of the capillary bed, the postcapillary venules. So you add the ACE or ARB, it relaxes the outflow tract that balances the pressure across the capillary, and the fluid gets reabsorbed. It works surprisingly well.
Huh. Good tip. Finally, just a quick safety check.
Oh.
Using beta blockers if someone have asthma.
You need to be careful. Non-selective beta blockers, the ones that block both beta-1, heart, and beta-2, lungs, blood vessels, receptors like propranolol, sotalol, are generally a no-go in asthma. Blocking beta-2 in the lungs can cause bronchoconstriction, trigger an asthma attack.
What about the cardioselective ones, like metoprolol?
They're safer because they preferentially target beta-1 receptors in the heart. But that selectivity isn't absolute, especially at higher doses. So even with cardioselective beta blockers, you still need to use them with caution in patients with asthma or reactive airway disease. Always ask about breathing problems before starting one. #outro.
Wow. Okay. We have really navigated the heart's electrical maze today. From the chronic risks of AFib and that crucial CHA-ARO-VAS score.
Right. Knowing who needs anticoagulation and remembering DOACs are preferred.
To the immediate dangers like that AFib plus WPW combination. Never give AV nodal blockers there.
Absolutely critical takeaway. And differentiating Mobitz I from Mobitz a third-degree block 1 you watch, the others need a pacemaker.
We hit tachycardia-induced cardiomyopathy, that amazing reversibility, and the need to always check a TSH in new AFib.
Don't forget HCM syncope, the murmur changes, and suspecting sarcoid in young people with heart block.
And the acute management pivots. Synchronized cardioversion for unstable tachycardia with a pulse.
Unsynchronized defibrillation for pulseless VTVF. Time is muscle and time is brain.
Plus those key drug facts. Amiodarone's lung and thyroid risks, the digoxin interaction needing dose cuts, IV haloperidol, and torsades.
Treat torsades with magnesium and beta blocker overdose. Glucagon to bypass the blocked receptors via CANT-MP.
It's a lot, but really practical stuff.
Definitely. And, the sources consistently point towards advances in non-drug therapies. Catheter ablation for WPW is curative. Pulmonary vein isolation is getting better and better for AFib.
Which leads to a final thought, maybe.
Yeah, something for you, the listener, to chew on. We see these complex drugs like amiodarone, with all their side effects needing constant monitoring. We also see these increasingly sophisticated, minimally invasive electrical fixes like ablation. So the question is, how far can these electrical interventions go? Could they eventually become the first choice before drugs for many common arrhythmias like AFib?
Where's that balance going to land in the future? Between the pill and the procedure.
Exactly. Something to think about.
A great place to leave it. Thanks for joining us on this deep dive. We'll catch you next time.